All right, good morning. Thank you so much for joining us today. My name is Bella Patel, and I'm incredibly excited to talk to you guys today about sickle cell disease. To start, can each of you give us your names and your medical specialties and how long you've been in your respective fields?
My name is Chien. I'm an adult and pediatric hematologist. How long have I been around for? Do you count training? Training is a lot, including training. It's been maybe more than a decade.
My name is Tami John. I am a pediatric stem cell transplants and gene therapy provider, and I have been doing this post-trainings for almost 10 years now. So very excited.
I'm Dr. Anju Goyal. I'm a pediatric hematologist. I think I am one of the newer members of the sickle cell team and have just finished training about a year ago.
That's great. All right, so to start off, we know that sickle cell anemia is a mutation in the genes that affect the hemoglobin structure in your body. So what exactly is hemoglobin and what does it do in your body? Why is it so important and why is this mutation so problematic?
Great question. So hemoglobin is a molecule in the red blood cells. So we know that red blood cells are very important. And hemoglobin is the molecule that carries oxygen. So it's what's responsible for delivering oxygen to your bodies. When there is the sickle cell mutation, it actually causes the hemoglobin to change its shape. And actually the entire red blood cell can change its shape and not deliver oxygen very well. So that's the consequence of having the sickle cell mutation. Interestingly, the reason why this mutation is so prevalent is because if you carry one copy of the mutation, if you're a carrier or a trait rather than having two copies of the mutation, this offers a little bit of protection from malaria. And because malaria was just, so deadly, if you could have any sort of protective advantage against malaria, it would offer you a survival benefit, which is why it's just so prevalent because of malaria. So it's kind of interesting how it evolved and why it's so prevalent. You want to, anyone have anything to add?
I think one of the things that I'll often highlight for my patients is why is oxygen so important? I think from a simplistic perspective, we always learn about it in biology, but I really go back to the root that it gives you and your organs all the energy it needs to do what it needs to. And so I think if you think of it from that capacity, if your body is not getting enough oxygen, it's hard for your brain to work, it's hard for your heart to work, and for you to do the things that you love and enjoy. And so we care a lot about your hemoglobin. You'll see us as physicians thinking about that because we want our patients to lead rich lives.
Great. So what exactly causes sickle cell disease? How can a patient, quote unquote, catch sickle cell?
Oh, well, sickle cell disease is a genetic mutation, so you can't catch it. You're born with it. And it does take two affected copies of the gene to inherit two copies of the gene in order to have sickle cell disease. So if you inherit, one sickle cell gene from your mother, one parent, and another gene, you can co-inherit thalassemia, hemoglobin C, are other things that you can co-inherit to also cause sickle cell disease. So you can't catch sickle cell disease, you're born with sickle cell disease.
And so what would happen if you were to only inherit one sickle cell gene?
That would result in sickle cell trait. Most of the time we consider sickle cell trait to be asymptomatic. Under extreme stressful situations, sickle cell trait sometimes can be symptomatic. So if you are going to very, very high altitudes or under extreme dehydration, I think the classic scenario is if you're in, boot camp for an army and you get really, really dehydrated, sometimes sickle cell trait can cause problems. But for the most part, we consider sickle cell trait to not cause any problems.
And as clinicians, what are some major challenges that you have all faced while diagnosing sickle cell anemia?
I think one of the benefits that we have is many patients these days are diagnosed initially looking at our newborn screen. And so all children who are born in the state of California have a routine blood draw, which helps us think through about many common medical conditions. And I think a lot of excellent work was done actually out of Oakland in the 60s in terms of making sure that sickle cell disease was one of the things that was actually included in that newborn screen. So I think in many ways, the benefit that we have is that we can get some initial testing. I think also science is so powerful in that it has given us all of these great tools to make diagnoses very early. I think the challenges I think that we face is often related to equity in terms of thinking about access to care. A lot of these things, if certainly if there's a family history, thinking about having those conversations prenatally, I think unfortunately, and then I think in making a diagnosis, sometimes there can be a challenge if there are some complex mutations that are going together that aren't the classic ones that we've seen. But I think I often say that science and society go together hand in hand, that it's so important for us to think about the biology, but the context in which a disease actually occurs to make sure that we understand what's going on and that we're advocating for patients to get the care they need.
So you mentioned screening as a way to diagnose sickle cell. So what are all the different ways that we can diagnose sickle cell? And what are some methods that clinicians tend to prefer to diagnose patients?
So as Dr. Goyal mentioned, sickle cell is picked up on the newborn screen. It's actually on the newborn screen, I think, in all states. So that is definitely one way that we get notified. If you want to confirm other ways that you can look at sickle cell disease, is actually looking at the blood smear. So you can see the name sickle cell disease is named after the shape of the red blood cells when you're looking at the cells under the microscope, and they have this sickle appearance. But the best way, no, not the best way, another way to diagnose sickle cell disease is actually separating out the different hemoglobins. And we call that hemoglobin fractionation. There's a lot of different names, hemoglobin electrophoresis. They all kind of mean the same thing, where you separate out the different hemoglobins. And then we can see that usually the sickle hemoglobin runs very specifically, so we can pick that up. And then, of course, there's genetic testing as well. And I think we're really moving towards confirming with genetic testing. And I think we've alluded to the fact that sickle cell disease is actually, there's a lot of different mutations that come together to make sickle cell disease. And then so you want to pick up those other mutations as well. And that can really help, look at, predict severity. And then there are some mutations that you can inherit that make the disease less severe. So I think we really are moving towards genetic testing to look at all of the other things. Yes, we can identify the sickle hemoglobin, but what are all of these other things that may make your disease more severe or less severe?
And even at baseline, a blood count, you can look and see that there's anemia. That's one of the hallmark signs for sickle cell disease is sickle cell anemia. And then from there, you can do these specialized tests that allow us to look at the sickle fractions and the genetic testing. But that's one basic way, along with the newborn screen, to look and see if there's anemia in the blood.
And I think we've touched on this multiple times, but you're diagnosed as a newborn with sickle cell. What are any scenarios that a patient could be diagnosed later on in their life?
I think that, again, we're so lucky to have the newborn screen, but I think other scenarios, certainly if we have folks who are from other countries, and I think that we often have, I think we always have an image of who can be affected by sickle cell disease, but I think the truth is, because it's a genetic disease that we know was initially with sickle cell trait protective against malaria, it's endemic in a wide variety of different areas. And then we've seen through immigration, through colonization, where things have spread. And so I think that if there is a suspicion for anemia, if you are seeing that, looking through, getting a good family history, looking at your blood smear, I think that they can give you clues that perhaps this was an under-recognized situation, perhaps due to where you were born or just overall how you have had access to care.
All right, and moving into what it's like to live with sickle cell anemia, there are many misconceptions about the difference between sickle cell anemia and sickle cell disease. Could you explain the difference between the two?
Well, the way that I look at it is that sickle cell anemia is a symptom of sickle cell disease. So individuals can have an anemia, but the disease actually encompasses so much more. That anemia, along with the sickling of the cells and the prevention of or the inability for the body to deliver oxygen appropriately, leads to then the entire picture of sickle cell disease. And that can look like so much more. Poor blood flow to the brain, to other organs, where you can see individuals have an acute stroke. They can have acute chest syndrome and other acute symptoms like pain events. Their spleens can swell. So there's so many different physical attributes that can happen when you have sickle cell disease. And anemia is just one of those symptoms, one of those attributes that we can see. And we also often recognize that if a person may have a baseline anemia, if that anemia seems to be worse suddenly, they may have worse symptoms. They may have some of these acute events that bring them to the hospital for pain management, for evaluation to make sure that their lungs, their heart, their brain, their kidneys are all doing okay. And long term, we can see this chronic sickling actually cause chronic organ disease as well. So it's kind of a two-phase disease with very acute symptoms and then long-term side effects when the body is exposed chronically to that low oxygen and low hemoglobin.
The one thing that I had just wanted to add was I think a natural question is, if you have sickle cell disease, why do you have anemia? What is it that's causing that? And I think natural questions can be, is it, am I not making enough hemoglobin? What's happened? And so I think that mutation, which is a very small, what we call a point mutation, it's a single change. It changes the shape of that protein, your hemoglobin. And so those cells, as already described, they form these abnormal shapes where they look like sickles. And so if you can think, because of that inherent change, they break apart more easily. And so that means that your body is actually quite smart. It does everything it can to rev up producing these younger, healthier red blood cells, but you're inherently always at a lower level where, unfortunately, you just, because of that change, your cells, I think of them, they're more fragile. And so that is sort of this first inciting step that then leads to all of those other more acute or really critically new onset symptoms and complications you can get, and those chronic changes that we see over time, in thinking again about why oxygen is so important for our bodies.
And we've been talking about a myriad of symptoms that are caused by sickle cell, and most of them aren't necessarily visible and you can't really see them. Are there any other major symptoms that aren't seen to the naked eye?
That's a very good question. I think what I worry a little bit about is always keeping a lens of what are potential complications of sickle cell disease. So one of the things that I'll highlight is thinking about when your brain doesn't get enough oxygen and thinking about strokes. I think, again, we have an image often of people who've had a lot of weakness, or maybe part of their face isn't working as well, or other things, but you may not actually see those overt changes early on. You can have more subtle changes, for example, not doing well in school, having a harder time focusing. And so I think that it's important to have really good conversations with certainly your medical team, trusted community resources, the true community, to think about what are some of those symptoms that are very classically seen and what are maybe some early subtle signs that warrant having more of a conversation about.
I think part of why it's so difficult to understand sickle cell disease is that you can't see what's happening when your body is not getting enough oxygen. They're not signs that you can see visibly, but it can be incredibly painful on the inside. So as all of this inside, whether your kidneys, your lungs, your brain, your heart, they can really suffer and struggle but not be visible. So it's very difficult to understand as a patient, and also understand, maybe your friends don't quite understand what's going on because everything is on the inside. So it's hard.
Fatigue too.
Yeah.
Yeah.
Oh yeah, and the anemia can, depending on the level of hemoglobin, can cause significant fatigue. So the hemoglobin, remember, is supposed to deliver oxygen to your body. And when your body is not getting enough oxygen, when your heart is not getting enough oxygen, when your brain's not getting enough oxygen, it actually, your heart has to work harder. So if your heart is working harder, your whole body is working harder, it can cause a lot of fatigue. So there's fatigue in that you can't catch your breath, because your heart is literally pumping harder to try to deliver oxygen to the body. But there's also just fatigue, as in, sleepiness, needing to take a nap because your whole body is working harder.
And you mentioned it's incredibly difficult to live with sickle cell, and you mentioned that it's really important for friends and family to understand what somebody is going through. So what are some things that friends and family could supply or do to support patients with sickle cell?
I think, this one's a hard one. I think being there.
Some things that I have learned from parents and advocates are really to listen and to really try to understand what your disease looks like. We know that sickle cell disease actually is a very variable. We see very variable symptoms, even within siblings who have the same gene mutations. Their sickle cell disease doesn't always look the same. Their symptoms are not equivalent across each person. So it's really important to, especially as you're younger, listen to your body, but also have people listening to you. As you start to, I think as a person with sickle cell disease starts to recognize some of their triggers, that can be helpful. I have some people that say that they can't be in cold weather. It triggers a pain crisis. They carry water bottles around because if they're a little bit dehydrated, if they go play basketball and they haven't drunk enough, then they have a crisis. Some people don't have those problems. Some people really respond well to heat packs or warm baths or massages, especially when they have significant pain. And so it really just is dependent on the patient, on the person living with sickle cell disease, but listening to them and trying new things to see if those can alleviate some of the symptoms. And then believing somebody when they do say they have sickle cell pain, they have shortness of breath, they are fatigued, because again, we don't see what the blood counts are until we actually test them. There's not a physical measure that we can apply that shows us that they are having a pain crisis or acute chest syndrome or other symptoms. So believing somebody when they say that they're having a change in their symptoms is really imperative.
I think one thing we haven't highlighted enough is that the main symptom of sickle cell disease when you're not having enough oxygen is pain. And I think it's so easy in friends, family, the community, even within medical professionals, to dismiss pain. And I think understanding that pain is very real and incredibly debilitating, and very real. I think that's something that's very helpful.
I think friends and family and really providing support to patients who are living with sickle cell disease, I think that they can be these tremendous advocates in terms of thinking about I think it is really hard to be a patient who has any chronic illness. And I think that it's so important to have someone who is by your side and can help be another champion for you, whether it's in a school setting, in a church, in a hospital, to be another voice, to help make sure that you're not being dismissed for other symptoms. I think that is really imperative to have that community.
And earlier you mentioned the emphasis on pain being the main symptom of sickle cell. What are some ways that you've noticed that your patients tend to try to manage that pain?
As Dr. John was saying, heat packs really help. I think I have heard of friends and family like just always carrying the heat pack for the patient because if in case they forget. Yeah. So being what's that?
Oh, layers of clothes.
Layers, heat packs, because cold temperatures can really affect. So extreme heat, extreme cold can really precipitate one of these pain episodes. So I think there are things that you can do at home, such as heat packs. Patients can definitely start with things like ibuprofen. If they're in the care of a sickle cell clinic or they have a provider, there's definitely medications that you can take by mouth. But a lot of times, the pain cannot be managed at home. So they need to really seek help at either an infusion clinic, the emergency room, and that's when we give IV or intravenous pain medications. Sometimes we can give them hydration depending on if they're a little bit dehydrated, we can give them a little bit of fluids. So those would be the things. And then if that is too much for the emergency room, which it frequently is, then we actually have them come into the hospital for more intravenous pain medication. And it's usually in the form of a little button where the patient can deliver the medication themselves, because it's hard, when you're in the hospital, if you're waiting for the nurse all the time to come deliver the medication, the nurse has to take a lot of patients. Sometimes the medication is not delivered quickly enough, which is why we like the patient control button. It's called a PCA.
And I think there's more and more evidence, and maybe Dr. Goyal knows more than me, for non-medication supportive care before or to maybe help prevent the pain from escalating so much. And so Dr. Chien mentioned the use of hot packs. Some kids will use like whirlpools. Their families have a setup at home or massage. But I think something actually more recent that we've heard great outcomes with are things like acupuncture and other supportive therapies that can help with muscle abnormality or with muscle pain, nerve pain, bone pain that comes with sickle cell disease when you have this lack of oxygen delivery that's causing these pain events. So there's a bigger body actually of literature we can read in medical literature now that things like acupuncture can really help people with their chronic pain and even sometimes prevent the acute pain from being so significant sometimes.
And definitely mindfulness, meditation. Oh, I think Dr. Goyal will know more.
I think that we have this really multidisciplinary approach to pain management. I think we're so lucky that we can build on these different layers, if you can think of it, of addressing pain from multiple perspectives. And I think a lot of that in these wraparound pain clinics, you can actually meet with a psychologist or a psychiatrist and to do some of those interventions that we call cognitive behavioral therapy in terms of how you're thinking about your pain, the effect that it has on life, and knowing that pain and mood are so finely intertwined. I think using those other practices that you can build into your life, whether it's mindfulness, meditation, even though we don't want you to get too dehydrated, certain exercises that I do think can help in terms of managing it. We have other things like acupuncture, as we've gained a lot of information about it, even different topical medications that can sort of trick your brain in terms of how you're perceiving your pain. And so I think working with a team of specialists is really helpful, because I think there's no one way to treat pain for all patients with sickle cell. I think it really requires an individualized approach in terms of what works well for the patient and their family, and trying to make sure that we also add as much normalcy as we can into life using all these modalities.
And this is still a bit of a developing field, but as far as treatment goes for sickle cell, what are some cases where secondary treatments or more invasive or intensive treatments are required?
I'm going to back up for a second because that's a very exciting topic. But the mainstay of therapy right now for sickle cell disease is Hydroxeria. And Hydroxeria is incredibly powerful. There's lots of data, that show the survival before hydroxyurea and after. And time again, they'll compare hydroxyurea to something else, and hydroxyurea is great. It basically increases this other hemoglobin called hemoglobin F. We have this wonderful nurse practitioner likes to call it hemoglobin fantastic. It's F for fetal, but it increases the hemoglobin F and can kind of dilute down the hemoglobin S. So hydroxyurea really right now is the mainstay of therapy, and really the most important thing that a patient can be on. We started at 6 to 9 months. Yeah, but this is life-saving. This buys you decades and decades of life. Before hydroxyurea, life expectancy 20 to 30. Even with hydroxyurea, we have work to do, but this, again, it is buying you decades of good quality life. So hydroxyurea is so important, and a lot of our clinic visits are anything we can do to help patients remember to take hydroxyurea, because it is hard to remember to take medications.
And I think to add to that, and probably Dr. Goyal and Dr. Chien are the best to talk about this, but once early, what was it, in the 80s, when we started recognizing sickle cell disease more often and intervening with hydroxyurea, as well as antibiotics that prevent infections that we know could kill young kids with sickle cell disease, the life expectancy actually changed dramatically. So within the United States, most children with sickle cell disease will live until they're in their 20s. If they're monitored with or taking these medicines in supportive care. What we see is a drastic comparison when you're looking outside the US in countries where they don't necessarily have access to these medicines or the education to provide these medications. So we do know that hydroxyurea and antibiotics are very, very powerful in helping to support somebody with sickle cell disease. These are medicines that are supportive. They are not necessarily disease transformative, but they have transformed the outcomes for individuals for decades.
So this is probably a good segue to Dr. John. Yes, hydroxyurea is so important. It is probably right now the best we have. We won't talk about voxelotor and crizanlizumab right now. They were available, they're not available or less available now. And of course, there's L-glutamine as well, just to acknowledge that. But so yes, hydroxyurea is amazing, but I think there's still work that we can do. So I think this is getting to your question at what else is there? So I think I'll let Dr. John talk a little bit more about that.
Yeah, and my job is actually to work with the hematologist that I'm sitting in the room with to recognize patients who need something more and recognize that we have newer therapies that can potentially transform their disease. And so these are individuals who are utilizing hydroxyurea and antibiotics and are still having lots and lots of symptom, even life-threatening symptom for sickle cell disease. And what we can consider now are therapies that some people call curative, but I think I like to call them at least transformative, where they can really change how sickle cell disease is active in the body. The two ways that I think about as far as something that's quote curative or transformative is utilizing a bone marrow transplant. So that is taking bone marrow that makes all of your blood from a donor and actually transplanting that into a person with sickle cell disease. So you're transforming their blood into blood that represents a donor. So you would choose someone who's healthy, who doesn't have sickle cell disease, and you transplant their blood into them and watch that grow. And it actually then replaces or changes. And in that case, we do use the term cure for sickle cell disease if we can see the new bone marrow growing. The other way is kind of now new and fantastic, but gene therapies, where we are utilizing science to modify genes within the bone marrow, and with those modifications, then transforming the sickle cell disease. So very similarly, we are actually taking bone marrow from a person with sickle cell disease, And I can explain that a little bit more. It's complex to think about bone marrow, but it lives with it doesn't live, but it's an organ that is inside of all of our bones and it makes all of our blood. But we can collect that bone marrow and modify it in the lab. So there are various ways we can modify it using viruses to add new genes, or using the CRISPR-Cas technology now to delete or cut or paste genes. And we do that outside the body in a lab. Once we do that gene modification, we can actually infuse those cells back into someone's bloodstream, and we watch them grow. And so now their blood is made of, it is coming from gene modified bone marrow that can overcome the sickle cell disease. So we see a transformation in the acute pain and the chronic, hopefully the chronic organ changes over time. So in any kind of bone marrow transplant, and so I classify a donor transplant, we call it allogeneic or donor transplant, and gene therapy under the stem cell transplant category. When we do these transplants, we have to have a donor source. So that's either a donor or the gene modified stem cells that we've made in the lab. And then we have to prep the patient. So we actually have to bring somebody with sickle cell disease then in the hospital. They're usually in the hospital for at least a month and a half or so. They receive chemotherapy that preps their body. So we have to find a way to clear out the bone marrow that they already have. That bone marrow that is making the sickled cells, we have to clear that out. And so instead of going and scraping bones or removing bone marrow in a surgical way, we actually can kill the bone marrow with chemotherapy. So we give chemotherapy for a few days, and then we infuse those new stem cells just like a blood transfusion, whether those are gene modified cells or if that's a donor stem cells. And then just like I kind of think of the bone marrow as like a garden. Just like a garden, we have kind of killed all the weeds. We have planted new seeds, and it takes weeks for those new seeds to grow and make a whole new blood system. So we have individuals in the hospital for another 2 to 4 weeks or so as we're watching the blood start to regrow. We have to support people with antibiotics because the immune system is actually part of the blood system that we kill with the chemotherapy. We have to transfuse. So we have to give blood and platelet transfusions to help make sure that you don't bleed or have very, very low hemoglobins until we start to see that growing back. So it's not an easy fix to do one of these transformative therapies, but it takes time. It takes weeks for us to see the body starting to regrow the blood, and even sometimes weeks to months for the immune system to recover after all of this.
Yeah, and I think it's definitely transformative, but no walk in the park, because I think we're looking at a minimum of hospitalization for 3 to 4 weeks, and then we keep 4 to 6 weeks, and then we are keeping a really close eye on the patient for at least 100 days, at least.
Yeah. And in a stem cell clinic, we would be following you very closely for at least 3 months, and then trying to space visits out to make sure that you're well, that your blood is still growing very nicely. But when we're talking about gene therapies, these are such new therapies that we have 2 brand new FDA approved therapies within the last year for sickle cell disease. These 2 therapies, while they're FDA approved, and you can get them outside of a clinical trial, so you can receive them as a standard therapy as long as we have insurance coverage and a way to pay for the therapy, and you have a place that can give the therapy. Not every institution, not every hospital can actually give this therapy. Very specialized places with stem cell groups that know how to do gene therapy can do this therapy for individuals with sickle cell disease. But even with these FDA approvals, we have very small timeframes where we've been able to, and very small numbers of people who've received these therapies. So we're looking at less than 10 years of data on how people have responded to this therapy. So the FDA is actually requiring for those who receive these therapies that me as a stem cell provider follow patients for at least 15 years. And that may look like just doing a blood count every once in a while, but to make sure that the therapy is still working and that their side effects of sickle cell disease have been stopped from the therapy. But it doesn't mean that that you don't get any medical care after you receive this therapy. And I think one important thing to note is for someone who's come in to a transformative therapy, we may stop all the acute problems. So maybe we are stopping acute pain events that are triggered by playing basketball and being dehydrated. But everything that's happened up until the time I do a gene therapy or a stem cell transplant, the body has already endured. And so there's only so much healing that can happen. And so what we have to think about is we can transform the disease now, but the symptoms that may persist because of a lifetime of sickle cell disease before that may not fully resolve. It may take time, and we may see healing in the lungs and the heart and the kidneys, but there may be some permanent damage that has been done that we also have to follow and monitor.
So these are actually really hard decisions that patients with sickle cell disease have to make, because on the one hand, you might have to go through this pretty intense and invasive process before you get too sick, because if you're too sick, you might not be able to tolerate such an intense therapy. And also, if you're too sick, it's possible the gene therapy won't be able to go back and correct the damage that's already been done. So it's these are difficult decisions that patients have to think about early on.
And I think one thing for a young person who's thinking about a transformative therapy, it's very hard. You're in the middle of junior high or high school. So right now the gene therapies are for those who are over 12 years of age, unless on a clinical trial that allows for younger. So you're thinking about somebody who's 12 or older, and making a decision to take time out of school to try to manage their health. And I spend a lot of time, and probably Dr. Goyal, I think, just with our interactions in the past, can attest to, I spend a lot of time talking to individuals about the risk-benefit ratio. And when does it become the right time to do such a big therapy, to know that I'm taking anywhere from 3 to 12 months off of work or out of school, and I'm going to lose my hair from this therapy. And these can be deadly therapies. Nobody with gene therapy up front has died from the therapy, but chemotherapy is a serious medicine that we have to give, and being in the hospital for a month and a half is a serious decision to make. So it's not something we take lightly to choose to move forward with these therapies, but understanding where the benefit might be for somebody who maybe is living with a lot of symptom of their sickle cell disease, and how we might be able to actually transform that for them.
I think, to echo what a hard decision this can be, I do think that we also are thinking about, as you're 12 years and older, thinking for families, they need to take time off of work. They need to think about potentially other children, childcare, all of these other pieces that we recognize. It's a decision that affects the whole family. I think also with patients with sickle cell disease, we've talked about, I think with any chronic illness, there's some inevitable component where this diagnosis, while we hope to create normalcy, does inform a lot of your values, your identity, your own perception of different pieces. And so it's really navigating this true psychosocial wraparound care in terms of what can your body tolerate and what is the right timing, but also what works for the reality of your own personal life in terms of your own perception of yourself and your values, your school life, family. I think all of those pieces require really nuanced conversations.
And we've been talking about how young patients have to be when they make this decision. 12 years of age is around the 7th grade. So they're in their developmental years of life, especially as their brain's developing. How do you think that impacts them if they do choose to go along with it around the age of 12? How would that impact them in their developmental stages?
I'll start answering that. I think I see 3 realms of age where I treat patients. With allogeneic or donor transplant, I actually often treat people younger. So I could do a donor transplant for almost any age, usually above 2 years of age. And if somebody has a match in their family, so a bone marrow match, then we can actually do that transplant very early. And so some families actually choose to have that therapy before school starts because they can arrange their life and they don't have to deal with or organize time out of school. Then we have this kind of second phase that we're now coming to where anybody, say you didn't have a donor, but now you have a sibling that matches in year 12, we could do a donor transplant, but now we have the second realm of gene therapy where you have to be 12 and over, at least for now. I think that may change in the coming years. But it's a huge decision. That's an age where individuals are learning to be with peers. They're growing. They might be starting puberty soon. They're just learning how to interact in the world and make their own decisions with the guidance of middle school teachers and friends. And so it is a year where we're out of that exposure to people that are your age. And that can be really difficult. We do try in the hospital to maintain school. So if someone's feeling well enough, we will have them working with the school to have a tutor, or the hospital can provide tutors and other schooling. But that direct personal interaction with someone else who's 12 or 14 or even 16 or 18, and the decisions you get to make when you're having more and more freedom are kind of thwarted for a little while. I will say that some of the individuals I treat can't go to school. Their sickle cell disease is so severe that they can't go to school, and so they're homeschooled. And so the conversation about a curative therapy is really, we're in the hospital all the time and we're not going to school anyway. We need something to change. And it's an opportunity for them to then go back to school and actually have those normal developmental milestones that they weren't otherwise going to have. So it's an interesting decision tree that we have to make for someone who's going to school and doing fairly well. That conversation of risk benefit actually really comes up in what's the risk of pulling somebody out of the environment that's going to allow them to grow at their age and develop appropriately.
And as you mentioned earlier, we've had a few developments in the past year, especially with CRISPR-Cas9. So the two new ones that are FDA approved are Casgevy and Lyfgenia. So what makes these treatments different from previous treatments that we've had?
I think just going back to what I have already described, the goal for these therapies for any gene therapy is to change the gene so that we can transform the disease. So we kind of have these two categories, at least in stem cell, where we define therapy as disease modifying. So Hydroxeria and some of the other therapies that we use for sickle cell disease they're disease modifying. And what we are hoping to achieve with one of the gene therapies is more transformative. So I think either way, it's modifying the disease, but we use this big term of transformative or curative with the gene therapies, and essentially it's changing the bone marrow so that we can have the body making its own normal blood, or as close to normal as we can get, so there are not sickling cells. And all what we see in the blood is all related to the success of the gene therapy.
I forgot to mention, I want to go back a little bit because you had asked, we've been talking about Hydroxeria, and then I think we jumped immediately to gene therapy when Hydroxeria isn't enough, but I forget that there is what we call exchange transfusions. So this is essentially getting donor blood and replacing the sickle blood with donor blood. And this involves oftentimes getting a line so that because you have to be accessed so much, and you come in roughly monthly to get this red blood cell exchange. So that would be an additional layer of therapy that we would offer. And we do this if we think that patients have really high risk disease, if we see that there's signs that they might have stroke, if we're seeing really signs of really significant disease in the chest, causing, maybe they have to be intubated because they've had such severe disease in their chest. If we see recurrent things, then we'll kind of step up to red blood cell exchange. But the red blood cell exchanges are really significant. This is kind of like chronically coming to the infusion center, coming to clinic, and sitting in a chair for almost all day. So this can really affect your lifestyle, your ability to hold a job, your ability to go to school because you're in the hospital so often. And that's why I think because these things are so affect your lifestyle, that then we think about the transformative therapies, the gene therapies, the Casgevy and the Lyfgenia that you were talking about.
I think if you want a way to think through all of the therapy options, I think the goal is to make your hemoglobin S lower, because we know that is what is causing these symptoms. And so with hydroxeria, you're trying to get up your hemoglobin F and trying to mitigate that. With the exchange transfusions, we're really getting rid of that hemoglobin S again. And then the gene therapy is really changing your genetic code to ultimately try to get a normal hemoglobin to really treat things. So I think there is a little bit of a spectrum of the strategies that are most appropriate at different stages in life, where your complications are in all of those pieces. But I think the ultimate goal is to go back to that root cause of your hemoglobin S and the relationship it has with oxygen and inflammation.
And just kind of going back to give more of a background on what Lyfgenia and Casgevy each are. Lyfgenia uses a virus to basically insert functional genes into your blood stem cells. So do you think that this method poses risk to patients?
All of the gene therapies right now come with a potential risk. So the two different gene therapies that we're using, there's three actually that we're using, at least techniques that we're using for sickle cell disease. And so one is exactly right. We're adding a gene. So using a viral capsid. So in this case for Lyfgenia, we're using a lentiviral capsid, almost like a Trojan horse. The virus doesn't work. The only part of it that works is the shell that encases a brand new gene. That allows this virus to, or that allows this whole Trojan horse to get inside the genome and actually dump the new gene into the stem cell, and then it can produce new hemoglobin. So there are some theoretical risks that when you're inserting something into the genome, is it going to insert into a place that maybe will trigger a cancer? And so what we're seeing with the Lyfgenia is that gene insertion is actually very random. And that's exactly what we want. We want it to be very, very random and very widespread, so that you aren't preferentially putting a gene into a place that might trigger some kind of leukemia or cancer. On the flip side, we're using gene editing with the CRISPR-Cas system with Casgevy. Instead of using kind of a Trojan horse system to insert something in, we're actually taking this CRISPR-Cas complex that's outside the body, that's utilized usually with other non-human systems, but we've learned how to train it almost to guide it so that it can go in and target one part of the gene inside of the stem cell and actually disrupt it. So you're not inserting something new, but you're disrupting part of the genome and then allowing that disruption to just repair naturally. And so when it's repaired, it no longer works. And so there's some theoretical risks there that you might not have a great guide, and that disruption occurs in problematic places. We're not seeing that with Casgevy, which is wonderful. But it's something theoretical, and one reason for both of these therapies, one reason we want to follow them up to 15 years is that we aren't seeing changes in the genes because of either that disruption or that addition. Third way that we're doing, and actually here at Stanford and across the bay at Oakland, we are utilizing CRISPR-Cas, again, that kind of trained system to go edit the genome to correct genes. So what we're doing on clinical trials, that we have two separate trials across the bay. what we're doing is actually using CRISPR-Cas to cut the little point mutation problem that we see with sickle cell disease. And then we have a donor template that has a new gene or a new amino acid essentially that pastes in. So unlike the CRISPR used for Casgevy, we're just cutting and allowing the body, the genome to heal or repair itself. We're cutting and then when it heals, adding a donor template. And that actually can convert that point mutation from sickle to non-sickle. And we're looking to see right now in clinical trial if we're going to make the normal adult hemoglobin from that. So still to come, but there are various ways we can do that. But anytime you're going in and you're adding or cutting or pasting to the genome, we worry that the body's so smart, it's going to repair itself. And is it going to repair in a way that it's going to trigger other problems? We think our current gene addition, the lentivirus gene addition approach and the CRISPR approaches are very safe in that we have not seen for anybody with sickle cell disease the gene therapy causing a cancer. We have seen the therapy itself, including that chemotherapy and the stress from sickle cell disease causing leukemia in very rare numbers of people. But the gene therapy itself is actually not triggering or causing cancers. We have we're getting close to about 7 years follow-up with the Lyfgenia product from clinical trial and closer to about 5 years follow-up for Casgevy.
And just as far as covering what Casgevy does, instead of replacing a mutated hemoglobin with non-mutated hemoglobin, we use a fetal hemoglobin. Why do we use fetal hemoglobin?
Yeah, so Casgevy is, as I alluded to, we're using the CRISPR-Cas to disrupt or break part of the immune system without that repair mechanism. And so if we just go and do that in the beta globin where sickle cell lies, you're going to not make any hemoglobin. So you're actually not going to fix anything. You're just going to take a mutated gene and you're going to make almost what we call thalassemia, a gene that doesn't even produce anything. So what we figured out though is if we can flip or switch the hemoglobin, so instead of producing sickle hemoglobin, the body can turn off the mechanism that turns off. So we turn on basically the switch to make the fetal hemoglobin. Then your body is switching back to making a normal type of hemoglobin. And I'll let Dr. Chien explain, but there's a whole science behind why fetal hemoglobin helps support sickle cell disease.
So fetal hemoglobin is a natural hemoglobin that we have when we're in the womb. I like to say that babies are little parasites. They actually need the fetal hemoglobin to leach the blood from the mom.
Extra oxygen.
Anyway, we don't have to be so barbaric. So fetal hemoglobin is the hemoglobin that babies in the womb use to get oxygen. And so it's a natural occurring hemoglobin. And then once the babies are born, that hemoglobin, the fetal hemoglobin kind of shuts off. And this has been a really important strategy for sickle cell disease. It's the hydroxeria that turns back on that hemoglobin F. And the more hemoglobin F or fetal hemoglobin that you have, it really is diluting down the sickle hemoglobin. So hydroxeria increases that hemoglobin F. This gene therapy can disrupt BCL11 and then turn on hemoglobin F. And we also know that high levels of hemoglobin F are actually naturally occurring in the population. It's called the hereditary persistence of hemoglobin F. So some people naturally have very high hemoglobin Fs. And in fact, I believe this is why we pursued this mechanism in the first place, because we saw that patients who naturally had high hemoglobin F, their sickle cell disease was more mild. So I think this goes back to the very beginning when we were talking about why is it important to genotype patients with sickle cell disease. It's just there's so many different modifiers, the different hemoglobins that inherit, but some things like do they have high hemoglobin Fs and other things like that.
And I think one point that I haven't described or explained, but when thinking about cure transformation, and I think this partially answers your question about the hemoglobin F, for the the two current FDA-approved gene therapies, one, we are adding that adult hemoglobin. We are not taking away the sickle hemoglobin that's already been inherited. And so what we expect is the outcome when we look at someone's blood is a mixture of sickle and a mixture of adult or normal hemoglobin. And one question arises if we're creating something like a sickle cell trait, which Dr. Chien described earlier as something that's asymptomatic. And so the goal for Lyfgenia or for the gene addition therapies is to create something that mimics sickle cell trait without necessarily getting rid of the inherited sickle genes. With the Casgevy, where we are upregulating hemoglobin F, we are ultimately trying to mimic either, and what we think we're doing is a bit more than just diluting the sickle hemoglobin, but actually trying to mimic that HPFH, that hereditary persistence of fetal hemoglobin, so that your blood cells have a mixture of fetal hemoglobin and sickle. So you still have your sickle genes, they're still making or producing sickled cells, but we are balancing the red blood cell out with a stable hemoglobin and an unstable hemoglobin. The gene correction that we're studying here at Stanford and in Oakland at UCSF, we are actually looking to correct that so that we are transforming sickle to an adult hemoglobin. So that's where we are hoping that maybe this correction could be something we call curative. But right now, the reason I shy away from saying the word curative, but transformative, is because we absolutely see a transformation in the disease. We see people who have had multiple pain crises after the therapy have virtually no pain crises at very high rates. But we're not quite correcting the genetics yet. So, yeah.
All right. And finally, we've noticed that all three of you have touched on the widespread problem of the accessibility, especially with CRISPR. Mm-hmm. So as far as like insurance and things along those lines, how can patients afford to receive this care through other financial means or insurance?
Yeah, that's something I spend a lot of my day trying to figure out. The stem cell transplant, so I can let May or Dr. Chien and Dr. Goyal talk about hydroxeria, which is relatively affordable but still problematic in some scenarios. But when we get to these transformative therapies, a stem cell transplant can be anywhere from $300,000 to $500,000 kind of minimum, and maybe even higher if there's complications. When we get to the gene therapies, we're talking $2 to $3 million just for the infusion of the gene modified stem cells. So that's without everything added. So we're getting to multiple millions of dollars for the therapy. The good news right now is that there is a CMS model, so state Medicaid model that is that some states are able to opt into to kind of support a cost payment scenario, not a cost, a payment scenario that may be effective or solvent long term. The bad news is that this is still very costly, and so getting insurance authorization is quite difficult. We are assuring that any patient we treat has insurance authorization. We also have to contract that we're going to get paid what we're asking for, because it's such a high upfront cost. So it's one thing if you make a contract and then somebody pays you 2 years later for a lower cost drug, but when you're talking about $3 million, you can't wait 5 years to get paid. So there's a lot that happens behind the scenes, but patients right now that are receiving the therapy are receiving it with authorizations by insurances that include state, like CCS in California does cover these therapies with certain indications and regulations. We have limited access worldwide, so far the United States is the only place where these drugs are available off of a clinical trial. In Europe and the UK, they have approved these therapies but are still looking through how they will pay for them in a socialized medical system, who should receive them. And then we have for thalassemia, so the same therapies applied to beta thalassemia. We've seen other countries like Bahrain and some individual countries within the EU that are able to give those therapies. We're recognizing they're high income countries where they maybe can absorb that cost for a certain population of individuals. So worldwide access is very limited. But I think aside from the monetary cost, Dr. Goyal brought up earlier as well, the lifestyle cost is very huge. And so there are limited places within even the state of California right now that can even give these therapies. So someone has to travel and live here in Palo Alto for 3 months minimum, sometimes even longer, and they've got to leave their job. They have to find ways to take care of their other children, pay for housing locally sometimes if we can't support them, transportation, food. If you're living somewhere that's less expensive than Palo Alto, then that's a huge lifestyle change, and then you're out of work and you don't have that income to help cover. So it's more than just the monetary cost. It really is, there's an equity barrier when you're talking about families that may even have multiple children with sickle cell disease living in areas that are outside of the Palo Alto area, and they have to seek care somewhere else. So it's very complex as far as equity, cost, payment, and we're still working on how to do it better.
I think that this conversation highlights, as you progress in therapy, how the finances can change. But I do want to highlight that unfortunately, I think that there is a high level of financial burden that's associated with sickle cell disease in general. I think folks out of Boston have done research about this, that throughout the course of a person's life, the time off of work, the childcare, the food, all of these other pieces ultimately have an impact. And I think one of our jobs as physicians is really to be mindful of that and thinking about how we then optimize clinical care to really meet a family's needs, and to also continue to advocate. It's certainly hydroxeria traditionally has been much cheaper, but as different formulations are available, that can change how insurances cover a life-changing medication, and what the out-of-pocket cost can still be. And so I think it's important for us as physicians to be scientists and advocates, because there is a huge financial burden.
All right, well, thank you, Dr. Chien, Dr. John, and Dr. Goyal, for speaking with us about sickle cell. It was truly an honor to be able to hear your insights on what's going on, especially currently. I truly hope our viewers can walk away with a better understanding of sickle cell and their options moving forward.
Thank you for having us.
Thank you.